Hi there, welcome to MedEd's production of the Medical Surgical Exam Review. My name is Cindy Smith and I'm here to talk about the pulmonary module at this time. As far as the module objectives are concerned, I'd like you to be able to describe the pathophysiology of various pulmonary diseases that we discuss in this module and apply the domains of practice described in the test blueprints to clinical practice for these disease processes as well. I would also like you to be able to develop a rapport with your patients and families and caregivers through increased knowledge of pulmonary diseases, and then also to implement the nursing process and promote positive outcomes for the patient with pulmonary disorders. The disorders that we're going to speak about today are anatomy and physiology, aspiration, ABGs, COPD and asthma, pulmonary medications, sleep apnea, blunt chest trauma, pneumothorax, pulmonary edema, and respiratory failure. All right, we're going to start off with a little pulmonary and anatomy and physiology first. So just to kind of review the upper and lower airways, remember on the right slide, the picture on the right side of your slide there is an example of, on the top part is the upper respiratory tract. So everything from your nasal cavity on down to your larynx is the upper airway. So air is transmitted through that airway, but nothing really happens other than the transmission of air. In the lower respiratory tract, we have from the trachea down in the bronchi and bronchioles and alveoli and things such as that. Most of that section also in the lower airway also deals with just the transmission of air from the inside to the outside of the body. It's not until you get to the respiratory zone, which includes your terminal bronchioles and your alveolar sacs, that actually is where gas exchange takes place. And if you can look at the picture on the left side of the slide, you can see that red mesh network type of material. That is your capillary network that surrounds the alveoli. And so you have a huge, extensive network of capillaries that basically come into contact with every alveoli that's in your lungs, and those cells are actually just one cell wide, so they have participation in gas exchange is where that occurs. So your CO2, which is in the blood or in the venous blood, can be diffused one cell width at a time through to the alveoli, and it all works on pressure gradients. So in a venous system, CO2 levels are a lot higher than in the alveolar sac, so the CO2 levels will diffuse through that alveolar capillary membrane and get into the alveoli. On the flip side, oxygen that you inhale is going to be higher concentration in the alveoli, so at that alveolar capillary level, oxygen will go into the pulmonary vasculature, into the capillaries there by a process of diffusion to get into the arterial blood so that can be delivered to the tissues. So basically your respiratory zone is where that gas exchange takes place. Everything else is basically just a conduit for air transmission, and we refer to that as dead space. There's two types of alveolar cells. Type 1 are the squamous epithelial cells, and they have a semi-permeable membrane in them, and that's where your gas exchange takes place. So remember what I just said with the O2 level. When you breathe in, the oxygen concentrations are higher in the alveoli, so at the capillary level, oxygen goes to that capillary from the alveolus. And then on the flip side, CO2 levels are higher in the venous blood, so that CO2 diffuses through the capillary level to the alveolus and is exhaled when you breathe. So the type 1 cells are responsible for that change or that diffusive property. The type 2 cells are the ones that produce surfactant, and you need surfactant in your lungs so that your alveoli don't collapse. So if you have somebody that has terrible pulmonary condition or acute respiratory distress syndrome or anything such as that, the surfactant properties are not functional like they should be, and so we can see a lot of patients that get into acute distress because of alveolar collapse. And then we can't oxygenate well, because if the capillaries don't touch the alveoli and make good contact, Maybe we have an alveoli that's shrunk, the capillaries are way up here trying to touch them, but they can't, then there's not good gas exchange. So surfactant's biggest job is to help decrease that work of breathing, prevent those alveoli from collapsing. With gas exchange, we'll talk a little bit about oxygen and then carbon dioxide. So we have to have oxygen for cellular metabolism. That's called aerobic metabolism. Now your body can function on anaerobic metabolism, but it's only functional to a certain extent, and it produces a lot more bad waste products than aerobic metabolism does. So you can't live indefinitely just using anaerobic metabolism. So we have to have oxygen. The usable form of oxygen in your blood is what's bound to hemoglobin, and then at the cellular level, oxygen is released by the hemoglobin and given up to the cells so that they can use them and carry on their processes. We measure that available we measure the available oxygen concentration in the blood with a blood gas. A normal concentration is between 80 and 100 millimeters of mercury. So when you get a blood gas and you look at that, you should see an oxygen level between 80 and 100 if it's a good one. Okay? We can also measure the saturation of the hemoglobin by looking at the pulse oximetry. And we want the pulse ox to be in the high 90s. We all know that in some cases of respiratory disease, COPD and such, that we're happy to have a high 80 value, but under normal, non-disease conditions, we want it to be in the high 90s. Carbon dioxide is a product of cellular metabolism, and that's carried in the blood so that it can be delivered to the lungs and exhaled. The dissolved form is what is actually exhaled out through the alveoli, or to the alveoli, and then exhaled out to the air. We measure the amount of CO2 in our blood by measuring the PA, partial pressure of CO2, and that number is 35 to 45 millimeters of mercury. And we can also look at the end-tidal CO2 levels, and what we do there is you can have a device that you can attach to the like an endotracheal tube post-operatively or something like that, somebody that might be on a ventilator, or even if you're ambuing them during a code, you can look at the end-tidal CO2 level to see if you've got good ventilation, because that's going to give you an idea of ventilation. Like, are we exchanging that CO2 like we should? And I'll talk about that in a little bit more detail in just a minute. All right, a couple of terms that you probably need to at least be familiar with are minute ventilation and alveolar ventilation. So let's talk about minute ventilation first. And that's the amount of air exchanged in 1 minute. And in a normal adult resting, we breathe in and out about 6 liters a minute. So I like to think of minute ventilation as the cardiac output is to the heart. Minute ventilation is to the respiratory system, so to speak. The formula for minute ventilation is tidal volume times respiratory rate. We can measure the respiratory rate. I'm going to put in a plug here. I hopefully won't say it again, but when you count respirations, it's very important to count it for a full minute, and teach your CNAs and other staff to count it for a full minute too, because you can't get a good gauge of respiratory rate if you count times 15 seconds and multiply by 4. That's not going to give you a good gauge of the rate. So count for a full minute, and then you can multiply that rate by the tidal volume. Now normally we're not measuring tidal volumes. Our cardiopulmonary staff are measuring the tidal volumes, and so they do that with a spirometer. Okay? And so minute ventilation is really everything we breathe in and out in a minute. So that's composed of the alveolar space and the dead space, that conduit too. So really, we know how much we're breathing in and out, but is it adequate for gas exchange? So we have another term that we use called alveolar ventilation for that. And remember when I was talking about end-tidal CO2 or even CO2 levels, we can gauge alveolar ventilation by looking at those CO2 levels. So if you think about it, alveolar ventilation is inversely related to the PA, or the partial pressure of arterial carbon dioxide. So think about it. If I'm breathing really, really fast, then I am going to be exhaling a lot more CO2. So the PA CO2 level is going to go down. So inversely related, if the PA CO2 is down, that means I'm breathing fast. If the PA CO2 level is high, that means I'm probably not breathing as fast as I should. So inverse relationship again, I'm hypoventilating. So there are, if we measure the PaCO2 or the end-tidal CO2 levels, which that normal is 35 to 45 also, then we can get a better idea of gas exchange. Are we ventilating in the alveoli like we should? So kind of think about that. If you have any questions to apply that to, that would be what you need to think about. It's inversely related. All right, so there's just some anatomy, and let's talk about aspiration for just a minute. Causes of aspiration. This list is not all-inclusive, just so you know, but some of the common things that we might see. Patients that may have been intubated. For up to 7 days, like a week after extubation, if a patient was intubated, a week after extubation, they're still at high risk for aspiration. So even though they're intubated, they're at risk, but even once they get extubated, they're still at risk. So they're not safe right away because they've had that tube in their trachea, and things don't close like they should, and bacteria can migrate and things like that, so they could aspirate. People that vomit, or even GERD. I've heard of people aspirating from GERD, especially in the middle of the night if they had reflux and stuff, they could aspirate. Patients that are on tube feeding, or those ones that have a suppressed gag or cough reflex, like the ones that may be over-sedated, maybe coming out of anesthesia, maybe have sedation on top of sleep apnea or something like that, or obstructive apnea, and then those with CNS disorders that maybe paralyze their respiratory system. So those are some of the primary reasons for aspiration or causes of aspiration. And then the manifestations. What does somebody look like if they are maybe at higher risk or if they are aspirating? So one of the telltale signs, if somebody is coughing when they eat or drink, that could be a big clue right there. You might want to stop and just do a dysphagia screening just to see how it turns out, and maybe they need to be evaluated a little bit further by a speech therapist for their swallowing ability. So coughing when eating or drinking. Another manifestation, maybe the feeding tube is not in the right place, so we have to check that feeding tube placement because that could be a manifestation that puts somebody at higher risk for aspiration. As far as vital signs are concerned, the SATs might go down. The respiratory rate and the heart rate might go up. One thing about saturations that I want you to be aware of too, though, is that SATs usually don't reflect immediate time. So if you're looking at an O2 saturation, it's about 30 seconds ago. So that basically means things could have already changed again by the time you actually see the value. So this just kind of is another plug for looking at trends and tracking trends and not just one value. Other things that might lead you to believe somebody is aspirated is shortness of breath or dyspnea, fever, especially if they've aspirated a bacteria that's causing an infection, cough, cyanosis, changes in their lung sounds, and that pink frothy sputum. Excuse me. Some other diagnostic tests that we might use to help with aspiration are blood gases. So in blood gases, if somebody's aspirated, they might appear hypoxic on the blood gas. So their PaO2 levels might be lower than expected. The chest x-ray might be done, and a chest CT might also be done. One thing to keep in mind is a chest x-ray is not necessarily going to show any changes right away, and it may take up to 2 days before any changes on chest x-ray become evident related to aspiration. So a better test, if you really feel like somebody's aspirated, to rule that in or out would be a chest CT scan. That will show more immediate changes than your x-ray will. So for management, the biggest thing that we really can do is prevent aspiration. So that's a biggie, especially in today's world, right? We have a lot of people that maybe have feeding tubes or NG tubes or maybe have been intubated. So when you have a patient that has a feeding tube, verify tube placement. We have a slide on that in just a minute, so I'm not going to go in any more detail on that, but verify tube placement. And do good oral hygiene. What I'd really like to say here is do it more than daily. That's not enough. We need to do it every 2 to 4 hours, I would think. I don't know if there's any research that's been shown to do it more, how often is often enough. But think about if you were the patient and you were intubated, or laying critically ill in a bed, or just really sick in a bed, and you don't get mouth care. How does that feel? You know, and there's bacteria in our mouth that can translocate, especially if we have a tube that's causing things to stay open that would normally be closed, like our glottis and things like that. So daily or more frequent oral hygiene is very, very important. The head of the bed should be up 30 to 45 degrees at least when you have tube feedings. And if anybody is at high risk, so if you're taking care of patients that are at high risk, make sure that you avoid bolus feedings, because you're putting a big, large volume of feeding in the stomach at one time. That's going to increase their likelihood of aspirating as well. So that's more of the prevention side. But what about, you know, once they do aspirate, if they do, what do? We can clear the obstruction. If there's something that we can see, we can do a scope, laryngoscopy or bronchoscopy, and get that foreign item, body out. We can do lavage, we can do suctioning and things like that as well. Not us as nurses, but the providers can. Fluid volume replacement is going to be really important, because we want to make sure that they stay hydrated. Antimicrobial therapy might be indicated based on what they've aspirated or what might be growing. You might be asked to get a culture. If you are asked to get a culture and give a patient antibiotics, just always make sure that you get the culture first, because you don't want to do antibiotics and then get the culture, because the antibiotics could actually make the culture not grow anything. So always, if you have both of those orders, get your cultures first. And then correct any acidosis. So kind of address the cause really, but correct your acidosis. And then give oxygen therapy, especially if their SATs are less than 90. So keep them higher than 90%. All right, so let's talk about feeding tube placement. What's the best way to confirm that you're in the right place? You really should use at least 2 of the methods that I have listed on the left of your slide. So that is, when you're inserting a feeding tube, assess for respiratory distress. If the patient's having respiratory distress, you're probably not in the right place. Or do the end-tidal CO2 or capnography. So looking for end-tidal measurements of your CO2 levels. Remember, 35 to 45 being your normal. You can also look at the pH of your aspirate, which we will talk about on the next slide, and then the appearance as well. So if it's in the lungs, it might have one characteristic appearance, whereas if it's in the stomach, the aspirate may look a different way. We'll talk about all of those in just a minute. So during insertion, at least 2 of those methods. And then once you've got it inserted, you would confirm placement with an abdominal x-ray. A lot of people want to say a chest x-ray, but abdominal x-ray, or KUB, is the correct x-ray procedure to take to validate correct placement of an NG tube. And then you want to make sure that you've marked and documented that exit site coming out of the nair. Okay, and then every time that you would go into that patient room, you would eyeball that and make sure it's still at that same site. And then check that tube location at 4-hour intervals after your feeding begins. So again, going in there to your room and assessing that patient regularly to make sure that tube is still in the right place. And then if you aspirate any volume, just look for changes in the volume of your aspirate rate. If any of you guys are still using the oscillatory method or water bubbling, where you put an air bolus in the tube and listen over the gastric area for that bubbling, that is not standard of practice. Do not do that. It is not. You can still hear sounds everywhere, no matter where the tube might be. You might hear it over the gastric area. So it's not a good way to assess tube placement. For gastric pH, which is actually the standard of care, and I know that a lot of facilities do not do that, but it's a very simple technique where you just take a little bit of aspirate and you measure the pH of it. And you can look at the color of the aspirate as well. If it's in the stomach, then it's going to be less than or equal to 5 or more acidic, okay? And it's going to be more of a clear to grassy green color. You might see some off-white mucus shreds, but your pH is going to be the telltale sign. If it's in the small bowel or the lungs, the pH is going to be higher, so over 6. In contrast to the small bowel, which might give you a yellow to brownish green or bile-stained aspirate, your lungs, if it's there, then the fluid removed there might look more like when you do a tracheal suctioning. This x-ray here shows good placement in the gastric area, and then this x-ray here, y'all can see the difference. It's gone into the right main stem bronchus. So if I were to tube feed a patient with that second x-ray that I just put up there, it's not going into the stomach. So if I don't validate placement and get it corrected if it's in the wrong place, I have to wait on the results before I start the feeding. I can't just get the x-ray and say, okay, go feed them. I have to wait until it's been verified before I do any feeding, because if not, I can cause trouble. And I've seen this happen before, so we don't want to go down that road. All right, so that was aspiration, and now we're going to go on to COPD and asthma. And this is kind of a blanket term. When I was first a nurse, I learned COPD consisted of what? Emphysema and bronchitis. And then asthma was a separate type pulmonary disorder that was a chronic disorder. But nowadays, chronic bronchitis and emphysema are under one umbrella, and then there's asthma as well that's kind of separate because the mechanism of injury is really a little bit different. But COPD encompasses both bronchitis and emphysema. So with COPD, it's a chronic inflammatory response to some kind of an irritating substance, whatever that might be, cigarette smoking or environmental pollutants or anything like that. It results in inflammatory changes, and what happens is the patient breathes, they might breathe air in well, but they can't get the air out. So it causes a hyperinflation in the lungs. So basically what I'm doing is I'll breathe, take a deep breath in, I breathe it in, but I can't get it all out. So then when I breathe in again, I've got even more residual volume in my lungs. So my residual capacities are going higher and higher and higher, really. The residual volumes are going higher, and I can't get all that air out. And as a result, I've got a lot of bad air in my lungs, and I don't have good gas exchange. And in a lot of your COPD patients, you understand they can't exchange gases good, so their CO2 levels go real high because they can't get it out. It also results in mucus production, and it does destroy the alveoli too. It's not fully reversible. So we can maybe manage it to a certain extent, but we cannot reverse the damage once it has been started. And so I alluded to cigarette smoking. Secondhand smoke is even also in that category. And then you can have environmental or occupational type hazards and exposure to those types of pollutants. But also keep in mind that COPD can be caused by a genetic disorder called alpha-1 antitrypsin. And in that case, the patient didn't do anything wrong to their body to make this happen. They didn't smoke or anything like that. It's a genetic problem. And they can be treated with the enzyme. I think it's an enzyme. So that enzyme, alpha-1 antitrypsin, can be given to that patient to help manage that COPD. And the rule is to suspect the genetic disorder in someone who's diagnosed with COPD at a younger age, like less than 45 years old. When we're looking at COPD, we're going to do some pulmonary function testing, and so some of these things you might need to understand or realize. So functional residual capacity. So let me tell you how to do that. I think I put it in your handbook as well, but functional residual capacity is measured when you take a deep breath in and then let it out. The patient with COPD, they're going to have a higher volume left in than normal. So that's why we get that hyperinflation and that air stacking, so to speak, because we're breathing in on air that's already in the lungs and we can't get it out. So that functional residual volume or capacity is higher than normal. I can't measure that as a nurse. The PFTs measure that through the help of our respiratory therapist, our cardiopulmonary staff. Another measurement that they might use in pulmonary function testing is the forced expiratory volume in 1 second, or FEV1, and that's going to be down. What they ask the patient to do there is take a deep breath in and blow it out as fast as they can, and it will be very difficult to blow that out with emphysema or with COPD. So it's going to be less than the normal. And we use the GOLD criteria to gauge the degree of alveolar destruction or COPD disease, so to speak. So you know how we have the ways to categorize the degree of heart failure? The GOLD criteria helps us categorize the degree of COPD. So gold 1 criteria means I've got mild pulmonary disease. Gold 4, the FEV1, the percent of that is very, very low, less than 30% of normal. So it's very severe lung disease. And then the moderate and mild are in between that. So what do we do to manage COPD? What kind of medications can we use? So there's a wide variety. Our beta-adrenergic agonist, or our beta agonist, those are our bronchodilators. And we've got short-acting and we've got long-acting. And I'm going to talk in more detail in just a few minutes. This is just kind of an overview slide here. We also have anticholinergics that are also bronchodilators, but they work in a different mechanism than your beta agonists do. And inhaled corticosteroids help with inflammatory response, systemic corticosteroids as well. You've got combination inhalers that are combined with bronchodilators and steroids. You've got newer drug delivery devices like Respimat that's more like a fine mist inhaler that can get deeper down into the alveoli. And then you also have phosphodiesterase inhibitors, and then an old drug that we've used forever and really isn't the best drug anymore to use are your methylxanthines like theophylline or aminophylline. So in the next few slides, I'm going to talk more in detail about some of those medications. In addition to those medications, oxygen is an issue with COPD. And so do we give somebody with COPD oxygen or not? So that's a good question, right? And I don't know what you've been taught. I was taught that if a patient has COPD, you don't give them any extra oxygen because it's going to make them stop breathing. So that's not 100% true all the time. So if you think about it, when we, as non-COPD patients, if we don't have COPD, our drive to breathe is a high CO2 level. So if we're not breathing fast or we're a little bit sedated or whatever, if our CO2 levels get up in our blood, it's going to tell our brain through these chemoreceptor mechanisms that we have, it's going to say, hey brain, you need to breathe faster, you got too much CO2 on board, so we're going to breathe faster. But if we have COPD, normally, or I won't say normally, but in some of your COPD patients, their CO2 levels are always high. They can't get rid of that excess CO2. So your body has to reset its mechanism to say when to breathe. Because otherwise you'd be hyperventilating like crazy because of your CO2 levels being high. So in a CO2 retainer COPD patient, their stimulus to breathe is hypoxia, not hypercarbia or a high CO2 level. So in that case, if we give them too much oxygen, they might stop breathing or that might depress their respiratory drive. So with that being said, everybody that has COPD, it's not, you can't give everybody with COPD oxygen. You can give some of them oxygen if that makes sense. If they're in distress, they might need it anyway. I mean, what's the worst case scenario is if they're in really bad distress, then it's going to have a bad outcome anyway, right? So, and they're probably going to be under your care, so it's a little bit different. As far as antibiotics are concerned, usually start with broad spectrum antibiotics. If you suspect a bacterial infection, and then maybe tailor it if you do have cultures. We want the patients to have flu and pneumonia vaccines because we don't want them to get a respiratory infection on top of a respiratory disorder. That is just a double whammy, and we just don't want that. We don't want them to smoke either, so we want to attempt smoking cessation. We probably all know people that have COPD and smoke, but we do need to try to get them to understand the reasons they need to quit. And then for nutrition, fewer simple carbohydrates is better in their diet and more complex carbohydrates. And the reason for this is when you break down the simple carbohydrates, it produces more CO2. And that's something that COPD patients maybe already have too much of anyway. So more complex carbohydrates. When you need to do patient education for your COPD patient, this is going to be a lot of recall as well as return demonstration, because you're going to talk to them about the use of inhalers and spacers and how to use them and how to demonstrate appropriate technique. Use your colleagues in the respiratory therapy department to help you with this. I know that some nurses are really good at inhalers and spacers, and some of them the respiratory therapists do. So depending on your practice is where you might need the help. Talk about medication adherence and making sure that they understand the difference between their inhalers, the types of inhalers. If they have a short-acting inhaler, it might be for rescue, whereas a longer-acting inhaler might be for maintenance doses. So if they're using their rescue inhaler all the time, what's going on? You know, why are they using that rescue inhaler when they should only be using it a couple times a month maybe, you know, under severe circumstances? So we need to get to the bottom of that. And so when they come to your care, ask them how many times a week they use or how many times a day or week they use, you know, each one of their inhalers. Pursed lip breathing is just an effort to get out that excess residual volume. Smoking cessation, flu vaccines is on there, pneumonia vaccines, and really when to notify the physician. Talk to them about noticing early signs of infection, and again, if we have an infection on top of a respiratory disorder, that it could be worse, have a worse outcome for the patient. Okay, for asthma, this is a chronic hyperreactive airway disease that is reversible, and it's more of a restrictive disease versus an obstructive disease like COPD is. So this is where you get airway inflammation, submucosal inflammation with white blood cells and mast cells and a lot of edema and vascular engorgement. It is reversible, like I said, but when you're having an asthma attack, it increases the work of breathing, and it can lead to hyperinflation because you get the air in, and again, you can't get that out as well. If you've ever heard the term status asthmaticus, that is a severe attack of asthma that is not responsive to traditional therapies. And so the picture that I've showed on this slide is, on the left, it's a normal airway. So we've got smooth muscle that surrounds that airway and keeps it toned. But when you have an asthmatic patient, it's even more toned. So it's more constricted. So that middle picture is an asthma airway under normal circumstances, and then the picture on the right is an asthmatic patient during an attack. That smooth muscle tightens down and causes that airway to get severely restricted. And so if you can imagine all that air going through, in and out through those little tight spaces, you hear that wheezing. That kind of makes sense. So status asthmaticus, if the patient is not responsive to your therapy, which we will talk about in just a minute, they're going to experience more acute shortness of breath. They're going to be in obvious distress. And they're going to be using those neck and stomach and rib muscles that normally we don't see people using. So they're going to use those accessory muscles, and they're going to be really doing that pursed lip breathing. When you hear expiratory wheezes, that at least gives you an indication that there's some airflow, but if the lungs go silent, that's ominous. So we don't want to let it get to that point. And so if the patient is not getting better, but they're getting worse, make your phone calls, make your reports sooner rather than later based on your assessment data. So how do we manage asthma? So we'll give them oxygen and then bronchodilators to help. Those are going to be your beta agonists, which again we haven't talked about yet, but we will in just a few minutes, to open up that airway. Steroids help with the inflammatory response. Magnesium sulfate is a smooth muscle relaxer, so you might give that to your patient to help decrease the constriction around those bronchi. And for long-term control, but not acute control, you might see the patient be prescribed leukotriene receptor antagonists like montelukast or Singulair, because the leukotrienes are inflammatory mediators. Excuse me, I couldn't think of the word inflammatory, but they're inflammatory mediators. So these antagonists would block those inflammatory mediators. And then other things that you might use with your asthma patient. What about triggers? What things are triggers? Does your patient know what their triggers are? Sometimes it's pet dander, sometimes it's stress, sometimes it's physical versus emotional stress. It can be heat, cold, just any wide variety of things now. So if they know the trigger, they need to avoid the triggers. They will be dehydrated, so you need to increase their fluids and provide humidification to their lungs as well, because all that airflow in and out is going to be very drying to the secretions. So we don't want their secretions to be dry. Otherwise, they're breathing through cement, so to speak, so it's going to clog everything up, so we keep them moist. BiPAP or intubation is also something that we may do. Now, we won't BiPAP over intubation, So where we use a bi-level of positive airway pressure, and so we never take the pressure off the airway to help keep it expanded. We're going to use BiPAP over intubation if it's working. Okay, intubation in most cases is the last thing we want to do because there's you know, a lot of negative consequences that could happen in relation to that. Okay, so considerations for nursing related to patient education. Again, I had talked about in other modules about making sure that your patient understands their disease process as well as their medication. In this case, it's the rescue inhalers, how often to use those and when to call the provider to say, hey, I need them more often, maybe I'm not controlled, and how to use their spacers. Peak flow meters are used for asthmatic patients in the home setting, so they need to be taught how to use their peak flow meters so that they can gauge their own disease process day to day and not wait till it gets worse. Know what signs of distress are and how important follow-up therapy is and what resources might be available to the patient. As far as monitoring your patient, as for nursing considerations with your assessment, the pulmonary status. What's the respiratory rate? Remember, respiratory rate count for 1 minute. And respiratory rate actually changes about 8 hours before somebody actually crashes. And so I think it's a vital sign that a lot of people take for granted and really don't pay a lot of attention to. But the literature that I have read says if we pay attention closely to the respiratory rate, we can head off bad events way sooner than sometimes we do. So pay attention to that respiratory rate, look at the work of breathing, and monitor your sats as well. And if you're doing end-tidal CO2 monitoring, you can use that as well. Infection, monitoring your CBC and your temp. How is your patient responding to antibiotics by looking at the CBC, what's their temp, and then looking at vital signs and I's and O's. So fluid status and hydration is really important too. For the core measure for COPD, it's monitoring for flu and pneumonia vaccine, especially in your high-risk patients. So, you know, in flu season, are we giving them their vaccine? Do they have the pneumonia vaccine? I know there's some age requirements for that as well. So just making sure that they fit the criteria and they get those vaccines. We all know nowadays, probably, that if a patient is readmitted within a certain period of time, most of the time it's 30 days, then we don't get paid for our services. So we want to try to do everything we can to keep our patients healthy at home and not readmit them because we're using resources on patients that maybe we could have prevented if we had done better education or assessed compliance better or adherence better or understanding better. So smoking cessation is also on that one. So let's get into some of the medications now. And we'll talk about oxygen first. And we'll start off with the low flow systems like nasal cannulas, simple mask, oxy masks, and some of your rebreather, non-rebreather masks, okay? So nasal cannula is going to give you about 24 to 45% of inspired oxygen at a flow rate between 1 and 6 liters a minute. So that's going to be on somebody that needs a minimal amount of oxygen. Okay, and you can set that. You need orders for all of these because oxygen is a medication, just so you know. Sometimes you have protocols you can work off too. But you don't necessarily just go start somebody on 6 liters. You have to go based on their signs and symptoms and what their orders are also. But that'll give you, a fair amount of oxygen for most people. Now, if they're a mouth breather and the cannula is not doing anything for them really, you may choose to use a mask. One thing I want to warn you about is the simple mask, and that is the one that's on the top right. That's a picture of a simple mask. And if you can imagine, there's no way for exhaled air to really get out. If the patient inhales that air coming in through the tubing there, when they exhale, there's no real outflow, so to speak. So they could start retaining CO2 basically because it's still in that mask. So those are ones that you might not want to use. I know a lot of facilities don't even have those anymore in their equipment rooms because they are dangerous if the flow rates are not high enough on that simple mask. So be careful with those. The oxy masks are the ones that we can use for our patients that are mouth breathers but still need oxygen. And you can see that on the bottom left picture. You can see it looks like a skeleton. Sometimes we call it a skeleton mask. So basically what that means is it's delivering oxygen through that tubing, but when the patient exhales, all their exhaled air gets out of that it escapes through those holes there. So there's not as high of a risk of retention of CO2. And so that, is a better thing, obviously. The partial rebreather is not often used, but it can deliver 40 to 80% of oxygen at a flow rate between 6 and 10 liters per minute. The non-rebreather is probably your go-to choice for acute situations, and that is the one that's on the bottom right or on the right side of your picture. You can see that there's an oxygen bag there. If you're going to use that mask, then what you need to do, you can deliver up to from 80 to 100% of oxygen, and your flow rate should be high enough to cause that bag to stay inflated. You probably are going to start at about 10 liters a minute, but you might need to go a little higher. You just don't want your bag to deflate all the way because, again, that could increase their risk of CO2 retention, and we don't want that. And another thing about the non-rebreather is it should fit their face well, so no gaps. It needs to be sealed good. Okay? So in an acute situation, in obvious respiratory distress, your go-to bag or go-to oxygen is probably going to be your non-rebreather mask. Nowadays we have high flow systems as well, and we have the Vapotherm or OptiFlow, and I'm not aware of any other. I'm not promoting these two, but I'm not aware of any others. But basically what they do is deliver a high flow of oxygen up to 60 liters with up to 100% FiO2 levels. So the high flow is going to help decrease the work of breathing, and the high FiO2 levels is going to help increase your patient's oxygenation. So in somebody that's in severe, significant respiratory distress, it's going to help with both of those, oxygenation and work of breathing. And it's going to probably be your last-ditch effort before either BiPAP or intubation. And so we want to wash out all that residual air and get as much oxygen to their lungs as we can. And it's very humidified as well, heated and humidified. So it's going to, I see a lot of that used in the hospitals today. You might also be familiar with what's called a Venturi mask. I don't see a lot of those used anymore, but that's a picture on the bottom right of your slide. And basically that is going to give you high flow oxygen at set delivery rate. So you can go anywhere from 28 to 50% oxygen or FiO2 by using the indicated adapter and setting the flow rate at the rate that's indicated on that adapter. If the physician has a concern about CO2 retention, you might see that Venturi mask used. But like I said, I don't see it used a whole lot anymore. All right, so some of the medications, other medications. Beta-adrenergic agonists, so your short-acting bronchodilators and your long-acting bronchodilators are your beta-agonists. And those are going to be bronchodilators, so they open up the airways. Anticholinergics are also in that same category. They just work through a different mechanism of action. Then you have your steroids, combination inhalers, Respimat, which is your fine mist, phosphodiesterase inhibitors, and Methylxanthines. So let's talk a little bit about beta-adrenergic agonists, or beta-2 receptors. So remember earlier in the cardiovascular section, part 1, I said that you have beta receptors in not only your heart and in your blood vessels, but also in your lungs. So the beta-2 receptors are in your lungs, and an agonist is going to stimulate a response. An antagonist or a blocker is going to stop a response. So in the case of bronchodilators, beta-agonists open up those airways by stimulating those beta-2 receptors. So that's really like your sympathomimetic medications. Your short-acting medications are your rescue inhalers, like your albuterol. And so that's what somebody is going to use in an acute situation where they're having trouble breathing and they need to open up quickly. The long-acting form of your bronchodilator that you might see a patient use is like salmeterol or Ceravent. Okay, so a spacer, which you see attached to this inhaler on the right side of the picture, is going to help improve delivery of the medications. So once again, you might need to do some patient education related to using that delivery system. Let's see. metered dose inhaler and nebulizer. So you can give those by either an inhaler or a nebulizer treatment where you hook it to the oxygen on the wall. So sometimes if patients in severe distress, they might need a continuous nebulizer hooked up. They can't just take, puffs of their inhaler, but they need that continuous treatment. Now, because it has that sympathomimetic response, it may cause tachycardia. So just be aware of that. Some of those these medications can cause the patient to get tachycardic. If your patient is on beta blockers as well, then these two drugs might antagonize each other. So again, just be aware of what medications your patient is on. Your anticholinergic medications are going to work by a different mechanism of action. They basically inhibit vagal stimulation and prevent airway smooth muscle contraction. They also help decrease mucus production, but they can also cause palpitations. So some of these medications just kind of make the patient jittery and a little nervous too. Your short-acting form of the anticholinergic bronchodilator is ipratropium, and the long-acting form is Spiriva. Spiriva brings up a good point for me because it may be more costly to your patients, and some of the patients might not be able to afford certain therapies that are ordered for them. So our responsibility as a nurse is to identify some of those problems and help find ways or resources for the patient to pay for those. Now, I'm not saying we've got to go out and get money for those or whatever, but you might use social workers to help, gather up some resources and get funds through sources that they know of too. The methylxanthines are what I referred to a little bit ago as aminophylline or theophylline, and those have bronchodilator effects as well. And those are drugs that have been around for ages. They have a very narrow therapeutic range. Some patients you may see, they have oral forms and they also have IV forms. And you might see patients on some of these medications occasionally, but not as frequently as we used to. They have reduced clearance in the elderly, so you have to be careful when you're using it on the elderly population, and they do have significant adverse effects. And so I found this little acronym somewhere in my research that said these are signs of theophylline toxicity: tremor, heart arrhythmia, so tachycardia. They shake a lot, they get really tremulous, they have tachycardia, they're really nervous and anxious, but it also can cause electrolyte abnormalities. It can, if the levels are too high, it can cause toxicity, pain in the abdomen, head problems such as headache, insomnia, or seizures. And glucocorticoids are your next category, and those can be in the form of systemic or local, like inhaled steroids. They have anti-inflammatory properties as well as immunosuppressive effects. We have to remember, though, when someone uses a glucocorticoid, about the fact that it suppresses the adrenal glands immediately. And so anytime someone is started on a glucocorticoid, they have to be tapered off gradually. They can never be stopped immediately. They can cause weight gain if they're used long term, and they can also cause hyperglycemia. So in a diabetic patient particularly, we need to monitor that. And then it also causes immunosuppression. And one other thing that long-term use of glucocorticoids causes is osteoporosis, so brittle bones, and they can have fragility fractures or things like that if they're on these medications for more than about a 3-month period of time. Combination inhalers can be used where you combine a long-acting bronchodilator and a steroid. You can have controller inhalers or quick relief or rescue inhalers in combination form as well. And then antibiotics may also be used in some of your patients. Do you get sputum cultures on everybody? Not anymore. But remember, if you are asked to get a culture, and this is any kind of culture before an antibiotic or in combination with an antibiotic, always get your cultures first. And then they'll start them on broad spectrum antibiotics until they get the results back, and then they may taper or tailor the antibiotics to that culture result if they did get a culture. Some of the community acquired pneumonias now don't necessarily require a culture anymore. The montelukast or Singulair are the leukotriene modifiers, and those block the action of leukotriene, and remember leukotriene is an inflammatory mediator. So not for acute attacks, but for long-term control. But these medications do have some side effects. They can elevate the liver enzymes and cause some GI distress as well. And they also have multiple drug interactions, so just be aware of that if your patient is on those medications. Okay, so that takes care of a lot of the medications that you'll see in the pulmonary section. And we'll move on to sleep apnea. And I don't have a lot really to talk about with sleep apnea, but I do want to talk to you about screening your patients and monitoring your patients that are either at high risk or have been identified as sleep apneic when they're in the hospital setting. So with some screening tools, OSA is obstructive sleep apnea. And so there are different tools out there. The one that I'm most familiar with is called Stop Bang, and each letter in that Stop Bang acronym is a question that you ask the patient related to their risk for sleep apnea. So in your handbook it has all the questions that related for that. So for example, snoring. Some of the questions would be, do you snore at night? Does someone say that you're really loud when you snore? Can someone hear you in different, if they're in another room and you're snoring, or behind closed doors and things like that? If you answer yes, you get a point. Are you tired when you should be awake? After a good night's sleep, so to speak, are you still tired the next day? Yes, you get a point. Has someone noticed that you stop breathing during sleep? Yes, you get a point. So every yes or every indicator that you fall out of, you get a point, and 4 points or higher puts a patient at higher risk for sleep apnea. Now that doesn't mean that we're going to go put CPAP on everybody in the hospital if they haven't been diagnosed yet, because they need a sleep study to get diagnosed. This is just a screening tool. But what it does mean is that if the patient is in the hospital and they've had a procedure like surgery where they're maybe more sedated or they're on a PCA machine or something, this means, hey, they're at higher risk, so I need to monitor them more carefully. Because when the patient is sleeping, you can see the pictures up there, normal breathing during sleep, the tongue does not fall back into the airway and occlude it. Whereas with obstructive sleep apnea, on the right side of the picture, you can see that that tongue relaxes and actually blocks that airway. That's bad for your body to have decreased oxygen levels in the middle of your sleep. So we want to be aware of that so that if it happens, we're aware so that we can address it. And there's different monitoring tools that you can use. I've used an acoustic monitor where instead of just doing oxygen saturations, they'll put a piece of tape that actually monitors airflow. So it's connected to, it's not just tape, it's got a sensor in it that measures or monitors airflow in the airway. So if airflow slows down, that monitor alarms at the nursing station or on your communication devices, and you can go in and check on that patient. So it doesn't mean I'm necessarily doing anything different other than monitoring more closely and trying to make sure that that patient doesn't get apneic. But with sleep apnea, the management of choice is CPAP. So they have to be fitted for a CPAP machine, and they have to be tested as well. So if your patient were to score at high risk for sleep apnea, the next step, other than monitoring while they're in the acute care setting, would be to get them in for a sleep study. Hopefully they will agree to that in an outpatient type setting or either in the home setting, because they can do them at home now too. So CPAP is the standard of treatment or first line treatment for sleep apnea. There's a lot of other lifestyle changes or dental devices and things like that that are on the market, but none of them have proven to be beneficial over the long term. There are some surgical interventions too. I have heard that most of those don't work either. However, I do know someone that had sleep apnea and had the uvulopalatopharyngoplasty, the UPPP procedure done, where they actually take out the top part of their airway back in the very back part of their mouth, and it actually did work. But they don't have a uvula or anything, so it looks really awkward. So if you ever see a patient that looks like that, you know, you might question them on what happened back there and did they have sleep apnea. So you may run across some patients that have that. There is another device that I just wanted to mention real quick because I know it's advertised on TV a lot, and it's called Inspire. And this is like the up and coming treatment for sleep apnea, where they put a device that looks like a little pacemaker in the chest, and they tunnel a wire or an electrode up underneath the skin to the back of the tongue. And they have a remote control that they can use, and an ENT doc would do this. But they have a remote control. They can turn it on at night but turn it off during the day. So at night it senses respirations, and every time you inhale it sends a very minute electrical discharge to the tongue that causes the tongue to contract so it doesn't obstruct the airway. It's called Inspire. I think that's the only one that's actually in production, or only one that I'm aware of, but the ENT guys are starting to probably put that in these days, so you might see that if you haven't already in practice in the near future. So it would take the place of CPAP. One thing about CPAP too is if the patient has already been diagnosed with sleep apnea, try to encourage them to bring their own CPAP, at least their mask with them, because it's fitted for them, and the ones that the hospitals have are not, they're kind of generic, so they're not fitted, so to speak, so they're not going to be as good as the patient's own. All right, that was all I had on sleep apnea or obstructive apnea, so that was pretty short. We'll go to blunt chest trauma and pneumothorax next. And in your motor vehicle crashes or falls or fractures of the bony thorax and things like that, you can get punctured lungs. And so, you know, most of the chest trauma is caused by wrecks, 70-80% motor vehicle crashes. But, you know, someone could fall and have a rib fracture and not necessarily have problems right away too. But your most common fracture in chest trauma is going to be rib fractures. And rib fractures are painful. We know that. They also make it hard to breathe in real deep. And so they can cause a lot of atelectasis and things like that. But one thing that we also need to keep in mind is that the fractured ribs can puncture lungs, but they might not puncture them right away. So if you get a patient that has been in some kind of blunt chest trauma and they fractured some ribs, they may go to the ICU for the first 24 hours first. A lot of trauma surgeons will do that because once again, the ICUs have maybe a better ability to monitor more closely and more frequently to rule out or in bad situations than you working on a med-surg floor could because of your demands that are placed on you. So rib fractures are the most common bony thorax fracture, and what's our biggest treatment? It's pain, right? Pain control is priority. It hurts to breathe and it hurts to cough. So we have to have pain control, but not to the point that we sedate the patient. So there's a fine line between control and overuse. So we want the patients to deep breathe. If they can do it manually, that's fine, but we can use the insuspirometer to help remind them and give them a tool to use also to help deep breathe. Keep the head of the bed elevated. It'll make it a lot easier to take deep breaths as well. So what happens if a blunt chest trauma and a fractured rib causes a pneumothorax? Well, we've got different types of pneumothoraces. And an open pneumothorax is going to be caused by some kind of a penetrating injury that comes like a stab wound from the outside of the body to the inside of the body, pierces the lung, and causes the pneumothorax that way. Closed is when we have the blunt trauma. And the worst case scenario is probably going to be your tension pneumothorax, where you have a closed pneumothorax, but it's under so much pressure and it's not been resolved that we've caused shifts in the pulmonary structures. So if left untreated, a tension pneumothorax can put pressure on the heart and the mediastinum and cause a decrease in cardiac output and obstructive shock. So that picture there basically is showing you the dark red on the left is air in the pleural space, compressing that lung and compressing the trachea and other structures in the thoracic cavity to the opposite side. And so if it causes a shift like that, then the signs are ominous that the patient's probably not going to survive it. So we want to be careful to not let this happen. So if you see what you see in the x-ray, it's almost too late. So tracheal deviation away from the affected side. So hopefully you can see right about where the tip of the arrow is, should be where your trachea is, but it's to the right of that. And you can see the bifurcation of the right and left trachea. or bronchus, they are way over to the left side of that patient's chest. What do we need to do to establish negative pressure? We need to get a chest tube put in that patient immediately. In the field, they're probably going to do some kind of a, they have new devices now they can put in to basically accomplish the same thing. But in the hospital setting, we're going to put chest drainage tubes in. So chest tubes, we may see patients that come in with injuries that need chest tubes for drainage of air or fluid. And air is a pneumothorax, but fluid could be like blood from a trauma, and that could be a hemothorax. So you can use chest drainage systems for both of those reasons. Sometimes we have patients that get a thoracentesis done for like a pleural effusion or effusions from cancer and things like that. Those are usually done by a needle aspiration in radiology. Those are also susceptible to developing a pneumothorax, but it usually doesn't happen for about 24 hours or within that 24-hour window. So be aware that those patients also require keen assessment skills to head off a negative situation. If you do have a patient that gets a thoracentesis and they have a pneumo, you're probably going to use a lot smaller chest tube. Some people call it a pigtail catheter, as opposed to a big, really big chest tube that trauma surgeons put in. But they're really basically designed to accomplish the same task. Now on your chest tubes, when they get inserted, before they get inserted, they'll put the drainage end that has all the holes in it in the pleural space. And then they'll attach the other end, and you can see the end of the chest tube on the left side picture. The end of the tube that's on the left side is the one that goes to the drainage system. The one on the right that has the blue line coming down the bottom there, that is, and pointing down, that's the side that goes into the patient's chest. You'll note that there's centimeter markings on there, so you want to note what centimeter marking comes out of the patient once you've got it all dressed. And there's holes in that end that go in the pleural space so that they can either drain air or fluid or both if they need to. The blue line is a radio-opaque line, and so when they do the chest x-rays, they'll know by that line where the tube is located. And if you can see on the right side of the chest tube, that's the left picture, there's a skip in that one line. That's the last hole in the tube. So if I see that skip on the x-ray as a provider, I can know where I'm at in the lung. So with your chest drainage management, a lot of nurses don't feel comfortable with this. So I want you to kind of think about three different concepts related to chest drainage management. And that's your collection chamber, your water seal chamber, and your suction control. This is one chest drainage system, and there are many. So I'm not promoting any type of system. This is just one that I'm familiar with, okay? The three columns on the right-hand side of your system are your drainage columns, and I think they drain up to 2,200 cc's or milliliters of fluid. So, depending on what your problem is, you might drain just air, which you can't see, or you might drain fluid, which you would be able to see. If it's a pneumothorax, you're not going to expect a lot of drainage. If it's a hemothorax, you might expect more. If it's a post-thoracotomy or something like that, you might also see some drainage. So monitor that accordingly. Now, if drainage is too much, like how much is too much? A rule of thumb in a trauma type patient is more than 200 mils per hour for 2 hours in a row is too much. So monitor your drainage hourly, at least initially, and let the provider know if they fall outside those parameters. In addition, if they dump more than 500 mils at one time, that's probably a lot as well. So you would call for that. Now, with that being said, if your patient's not been real mobile and they've been laying in one position for a long period of time, they may dump if they move. That's not necessarily bad, but you'll want to do an assessment and see what else is going on, if there's anything else going on. The water seal chamber is the bottom left-hand picture, or of the picture, about where that letter C is. You can see that white dotted line. That's your water seal. You need at least 2 centimeters of water in order to keep the seal there so air doesn't enter the pleural space from the outside. And so basically what you're doing there is just creating a water seal so air can get out when the patient exhales, but air can't get back in when they inhale. So you want to keep that where it needs to be at all times. And then there's a suction control chamber. In this particular device, you'll hook your suction tubing from the wall to the device, but that orange dial there that you see is on I think it's on the -30 right now. That indicates that it's at 30 centimeters of water suction. And to set that, you'll just turn the dial, which is a little device on the side of the monitor, to the desired setting, and then hook your suction up on the wall to your machine about where the R is on top of your device. There is where you hook your tubing, and you turn your suction on your wall on until that orange bellow right below the letter E in blue comes out to the triangle mark. And if you're not familiar with all that, just take one and play with it, or ask your hospital educator to help you with that. But that sets your suction, okay? So there's a lot of what-ifs with chest drainage management. And so I have a lot of what-if scenarios in your handout, like what would you do if the whole tube came out of the patient? You'd put a Vaseline gauze over the site, and you'd tape it on 3 sides so air could get out but it can't get back in. What would you do if your tubing came disconnected from your chest tube and the chest tube stayed in the chest? Then you would put the end of that chest tube under some sterile water to create a water seal so you can get a new setup. So there's some what-if scenarios in your handout that you should review and try to be familiar with as well. All right, a pulmonary embolus is a blood clot in the lungs, and if it's big enough, it can cause really bad problems. And sometimes they are really big, and they're called saddle emboli, where they sit at the bifurcation of an artery where it branches, whereas sometimes others can be really, really minute and not cause any major trouble. So depending on the size and the location of the embolus is going to depend on what your symptoms are and the patient's outcome. But if we talk about things that make your patient more susceptible to a venous thromboembolism or some kind of a blood clot, we talk about Virchow's triad. So that's venous stasis, or low flow states of blood, vessel wall damage. So remember, anytime any vessel wall is damaged, what happens? Your body tries to clot it off, and then combine that with a hypercoagulable state, and you get a perfect storm for getting a VTE or a venous thromboembolism. And if they break loose, thromboembolism means it broke free and it went to another area. Oftentimes a venous one goes to the lungs. So what does somebody look like that has a pulmonary embolus? Well, they're in respiratory distress, right? They're tachypnic. They have a decrease in their PaO2. Why do they have a decrease in PaO2? Because they can't breathe, because they've got this big occlusion in a vessel that's preventing blood flow from getting to the alveoli to get gas exchange. You might see them have hypocarbia, which means their CO2 levels might go low because they do hyperventilate the tachypnea, and CO2 diffuses faster and easier than O2 does, just so you know. So you might see a decrease in the O2 levels sooner than you see changes in their CO2 levels towards the negative, okay? Depending again on the size, you might see pain, sharp stabbing in the thoracic area. And a medium or small clot is not going to be nearly as significant as far as the manifestations as that large, massive clot will, and that can actually cause obstructive shock, where blood flow can't get from the right side of the heart to the lungs because there's a huge occlusion. The test of choice to confirm PE is spiral CT. So that's your test of choice. Angiography is another test. It will be just as definitive as a spiral CT, but spiral CT is less invasive. So depending on what you're going for, you can get the same results. Management, prevention is a big deal. What do we do to prevent DVTs or blood clots and prevent them from traveling to the lungs? We use preventive interventions in the form of mechanical devices or pharmacologic devices like Lovenox, heparin. Some people use aspirin. So that's your preventive interventions. If they've already got a PE, then they might get oxygen, fluid volume resuscitation in the form of crystalloids, analgesics for pain management, anticoagulation. Now remember, anticoagulants do not break up the clots, but they prevent them from extending and prevent more from forming. So they'll probably be on some type of heparin infusion. They can give them a thrombolytic agent into that actual clot in the lungs. Usually it's in interventional radiology that they do that. They can take them to surgery and do an embolectomy, or they can use a device called ECHOS, endosonic endovascular treatment, where they actually have like a little roto-rooter type thing. They put it into the vessel. They would do it in interventional radiology, but it's just like doing a right heart cath, where they put this this device in the vein, and they go into the inferior or superior vena cava, wherever they put it, and they guide it into the affected artery, and then they use ultrasound to break it up, and they also lyse the clot right there by using a TPA solution. So that's ECHOS, where they can actually do that. And then an IVC filter is your last ditch effort, really. That used to be kind of a go-to procedure, but that has so many complications and it's so controversial that they don't really like to do those anymore if they can get away with it, because there's just been a lot of complications with those. So nursing considerations: implement your VTE protocol, which basically means get those SCDs and TEDHOs on early. Use your risk scoring tool. A lot of people that I talk to in this area, the physicians or the providers are the ones that do the scoring, and the nurses don't really know what the patient's risk assessment is, but some nurses do the risk assessment tool, use those and score them, and then that information gets relayed to the providers. So there is a tool that you can use, and I think it's Dr. Caprini that invented or discovered that tool. So there's a lot of different risk factors that you can look up if you feel inclined that would put your patient at risk of some form or another for developing a DVT. Educate your patients on the risks and signs and symptoms of PE, because PE can lead to respiratory failure, so we don't want that to happen. We want to prevent them as much as we can. And get your patients up and moving early, so get them on their feet as soon as possible. Pneumonia, that'll be our next topic. And pneumonia, I have it divided into a typical presentation and presentation in older adults, because we all know, if we've got any experience at all really, especially experience in long-term care, that our older adult population does not always present with the same signs and symptoms that a typical non-elderly patient would. So they don't necessarily have that fever and cough and shortness of breath. They've got more signs of confusion and lethargy and maybe some behavioral problems, and we think, what in the heck's going on with them? I know when I first started in long-term care, I didn't realize that. And we were doing a care conference one day, and this lady had a UTI, not pneumonia, but the concept is about the same. And the dietitian of all people said, oh, she's really confused. I think she's got a UTI. And I'm like, how do you get that? But it's true. The older adults present in a lot different way than the typical presentation is. So think about that in your older adult population. In addition to fever, cough, shortness of breath, increase in the white blood cells, and that tired feeling and muscle aches and all that your typical pneumonia presents with. And then some of the other diagnostics: chest x-rays identify and infiltrate in the lungs. Sputum, maybe you are asked to get a sputum, maybe not. Everybody, like I said earlier, is not asked to get a sputum. CBC, you're going to look at the white count to see if it's responding to your antibiotics if you've started them on treatment. And then your other lab work, this is if your electrolytes or your renal or liver functions are maybe not normal, then that might be an indication that they need to stay in the hospital or be admitted versus being treated as an outpatient. So respiratory failure can occur for a wide variety of reasons. Pneumonia is just one of them, but I have respiratory failure divided into 3 different sections or reasons for occurring. So I wanted to focus just on the middle one for a minute, because those are your pulmonary causes. So pneumonia can cause respiratory failure, but so can a pulmonary edema or COPD or a pleural effusion. So anything that damages or impairs the lung tissue so that it impairs gas exchange can cause respiratory failure. So some of these, we didn't talk about every single one of these respiratory diseases, but just try to have an understanding of how these different diseases affect diffusion of gases across the membranes because of the insult that might be incurred from them. On the other side of the slide is the left side, which is traumatic. So these are things that, traumatic injuries that can cause the respiratory system to fail, like a flail chest. And I think you probably know that a flail chest is when you have fractured ribs in multiple places on the same rib, and more than one rib is fractured in multiple places. And so it basically causes paradoxical movements, and it sets them at high risk for pneumothoraces, which is also going to be a higher cause for respiratory failure. Severe head trauma, if the brain doesn't know that it needs to breathe because it's got severe head trauma and cerebral edema, then you're going to have respiratory failure. Spinal cord injury, remember C1, C2? Anything higher, that's as high as you go. You get a fracture there or a break in your spinal cord, they're not going to breathe. So that's why we have to be really, really careful with some of our spinal cord injuries and our fractured backs and things. When we move them, we don't want to cause any more damage because it can cause respiratory distress or respiratory failure. And then you also have the neurologic category. We will talk about a couple of these later on in some different modules, but anything that kind of paralyzes your respiratory system, whereas it's your muscles or just makes you not have that drive to breathe neurologically, can also be a cause of respiratory failure. The manifestations of respiratory failure, probably the biggest one is a change in mental status. So they were alert 3 hours ago and now they're confused. Is that significant? Of course it is. Is it significant because they're in respiratory failure, or is there something else going on? Until you do further investigation, you might not know, but it's a cause for concern that you need to investigate. So change in mental status, a lot of times it's due to all that CO2 building up. Cyanosis, lips, oral mucosa, nail beds. In the darker colored or darker pigmented population, oral mucosa is better and your conjunctiva is better maybe to look at cyanosis than the nail beds or the lips. And then listening to breath sounds. When you listen to breath sounds, listen on bare skin, front, back, top, bottom, sides. Okay, not over their gowns. And then look for adventitious sounds, such as wheezes or crackles or absent sounds even. And then other signs of distress, things like accessory muscle use, pursed lip breathing, flaring of their nostrils. All of these signs can indicate that respiratory failure is occurring. And in this case, this x-ray here looks like a really, really bad sign of acute respiratory distress syndrome where there's almost a complete whiteout in the lungs, which is a pretty ominous sign. Diagnosis of pneumonia in particular, it can be diagnosed with an infiltrate on the chest x-ray, leukocytosis, which is an increase in the white count, and then fever and culture being positive. So management, what do we do with somebody that has either pneumonia that's really significant, causing respiratory distress, or other reasons for respiratory distress? We want to use high flow oxygen. So this is where that OptiFlow or Vapotherm might come into play. We want to make sure that we get them breathing, so using an spirometer and giving them targets to try to deep breathe to with that, and using maybe positive expiratory pressure oscillating, so chest PT, so to speak. We want to keep them off the ventilator unless we absolutely can't oxygenate them any other way. And then don't forget about some of those preventive interventions too that you use for like DVT prevention, so your mechanical and pharmacologic interventions, stress ulcer prophylaxis, PPIs. There was a point in time when I think people thought PPIs caused more of an incidence of C. diff. Not always the case. I think it's kind of gone back and forth, but I think right now PPIs are good to use for stress ulcer prophylaxis. Diuretics and steroids help as well. So, so some of the other management in addition to oxygen. Assess your patient and monitor for changes or changes from their normal or declines or trends in cyanosis, in their breath sounds, in their respiratory rate, SATs, and lab values as well. And then what do we do for our patients? Nutrition is really important. So what about somebody that can't breathe? Are they going to eat? No. But our respiratory patients are probably the ones that need it the most because it takes a lot of calories if you're in respiratory distress. So how are we going to feed them if they can't eat or if they're too weak to eat? Are we going to use a tube feeding or are we going to use IV feeding? So those are choices or discussions that you need to initiate if someone else already hasn't. Don't forget about hydration, increase their fluids. Don't forget oral care. Bacteria can translocate, and that can be a bad thing in the setting of intubation. Turning helps aerate the lungs, helps decrease pressure in different areas. Is spirometer basically with aeration of the lungs, and just other supportive devices that help prevent other complications. Sedate them if you have to, but use it judiciously. Okay, the last section before we get to the review questions is going to be on blood gases, and this one often gives people a little bit of a challenge as well, because a lot of nurses depend on the respiratory therapist to do blood gases. So I just want to give you some helpful hints on blood gases and go through a couple practice ones as well, so that you can kind of get a feel for interpreting them. And I have a chart in your handout that will help when you're doing the slide presentation. If you want to use that as a guide, that's fine. But your body has to maintain a normal pH, otherwise it's not going to work appropriately. So we've got short-term mechanisms to help maintain acid-base balance in the form of buffers, and then we have longer-term systems in the respiratory system and the metabolic system or the renal system. So lungs work faster than kidneys. Okay? Okay. We have to have a normal balance of oxygen at 80 to 100 millimeters of mercury in order to have aerobic metabolism. So don't forget that aerobic metabolism is our desired, because anaerobic metabolism produces lactic acid, and that's a bad thing for the body over the long run. Okay? So know what your normal O2 levels should be and what your patient's SATs are, and they should be in the high 90s normally. When you talk about pH, that just gives us an idea of the hydrogen concentration in the blood. Normal pH in the blood should be 7.35 to 7.45, and it measures the amount of hydrogen ions. So the lower the pH, the more acidotic the condition is. The higher the pH, the more alkalotic the blood is. CO2, normal blood level is 35 to 45, and it's a respiratory gas because we blow it off as we breathe, but too much CO2 is an acid. So CO2 is a respiratory acid. Higher than 45, it creates an acidotic state, and lower than 35 reflects an alkalotic state. Bicarbonate is our renal component of the blood gas, so the metabolic component. And that bicarb is a base. So normal being 22 to 26 millimeters of mercury. If the bicarb levels are low, your patient is more acidotic. And if the bicarb levels are higher than 26, it reflects a more alkalotic condition. When you're interpreting your blood gases, you're going to use all of those components that I just mentioned. The first thing you want to do is quickly look at the PO2 levels, because if they're not normal, we're looking for hypoxemia, less than 80. If they're not normal, we need to do something about that. But sometimes those are normal, but we still have an abnormal blood gas. So look at the pH, the CO2, and the bicarb. And then ask yourself, is this a respiratory or a metabolic problem, and is it acidotic or alkalotic? So as we go through the exercises, I think this will help you a little bit. And really, it's the seesaw effect. We want these systems to work together to maintain normal blood pH. So keep it in the middle. Your respiratory and your metabolic or kidney function needs to be good in order to have a good blood gas. So some people refer to this as tic-tac-toe, or whatever you want to refer it to. So I put all the normals in the middle. If you look at the PaCO2 level, though, you'll notice that the CO2 levels are flipped. So the high CO2 is going to be on the left side, and the low CO2 is going to be on the right side, because a higher CO2 is more acidotic. So when you're looking at your blood gases, if you use your neutrals, then you can put little check marks in your grids as you get them to indicate acid or base. So here's one, and I did put the normal values in here just to help give you a guide, but they're not in your handout. So what I would say here is work through your handout first and see what you get, and then pause the video maybe here, work through it, and then come back to the video and see what you got compared to what the answers might be. In this case, our pH is 7.40, the CO2 is 40, and the bicarb is 26. So our pH is normal. So I put an X in the normal column. So that's what I'm going to do from this point forward, is where my X's will go, I'll call them out. The CO2 is 40. That's normal. And the bicarb is 26, so that's normal. So my interpretation of this blood gas is going to be a normal ABG, and this is anything in that normal range is what we're desiring for our patient. But it's when you get abnormals that maybe you have some trouble and that you need to do some investigation and try to figure out what we need to do. So, okay, so the next one, the pH is 7.26. In this case, it's acidosis. The CO2, PCO2 is 59, and that's also acidosis. And then the bicarb is 25. That represents a normal state. So here our blood gas interpretation is, where's our pH? It's acidotic, and which one of our other factors is on the same side, so to speak, as our acidotic pH? It's the respiratory system. So it's an acute respiratory acidosis. And we know it's acute because we have that pH out of the normal range, and that other system opposite of the primary problem is still in their normal range as well. Things that can cause acute respiratory acidosis, again, not an all-inclusive list, but some of the patients that you might take care of are drug overdose patients, people with pulmonary disease or head trauma, COPD, pneumonia, and a wide variety of others that basically depress the respirations. The in this next example, the pH is 7.50. In this case, it's higher, so alkalotic. The PCO2 is 29. In this case, it's lower than the normal range, so it's alkalotic. And the bicarb is 25. In this case, that's normal. So this blood gas follows an alkalotic condition, and because the respiratory component is on that alkalotic side, it's an acute respiratory alkalosis. Things that can cause acute respiratory alkalotic conditions include anxiety, fever, pain, liver failure, CNS disorders, and a wide variety of neuro problems as well. So again, if you're looking at your blood gas, use your normal values to help guide you as to what your interpretation is. With a pH of 7.21, it's acidotic. The PCO2 is 40. That is normal. And the bicarb level is 19, which is low or acidotic. So in this particular gas, it's an acute metabolic acidosis because our renal component or the metabolic component follows the pH. Things that can cause acute metabolic acidosis are things that y'all probably see often. Shock, end-stage renal disease, diabetic ketoacidosis. One of the anti-diabetic medications called metformin can also cause it. Some other GI problems like diarrhea or GI fistulas can also cause an acute metabolic acidosis. With this pH, it's 7.53. That's higher than normal, so alkalotic. The PCO2 is 39. That is normal. And the bicarb level is 36, and that creates an alkalotic condition. So in this case, the interpretation is acute metabolic alkalosis. Things that cause acute metabolic alkalosis include diuretic use, loss of hydrogen ions through NG tube drainage or excessive vomiting, maybe the ingestion of alkali drugs like antacids. Hypokalemia can also cause it. So again, keep these in mind as etiologies for your blood gas problem if you see that abnormality. So more practice ABGs. pH is 7.33. These are just going to give you a chance to run through them. I'm not going to ask you why they might have been caused, but just do interpretation. So 7.33, acidotic. PCO2 of 62 is acidotic. And the bicarb level is 32, which is alkalotic. Okay, so now everything's out of whack. So follow, your primary problem is going to be on the same side as your pH problem, okay? So your problem is a respiratory acidosis, but it's partially compensated because the opposite parameter is also not in the normal range. So what that bicarb is trying to do is pull the pH back to the normal level, because that's what your body tries to do, is compensate. All right, 7.32 pH, acidotic. The PCO2 is 31. That is alkalotic. And your bicarb level is 20. that is acidotic. So what is my problem here? A partially compensated metabolic acidosis. So follow your pH. It's acidotic. Your bicarb is acidotic, so that's metabolic. It's partially compensated because the respirations are trying to blow off that respiratory gas of acid of CO2 to try to pull that pH back to the normal range. pH is 7.35. Normal, but on the lower end of normal, okay? And I put that over to the lower end of normal for a reason, and I'm going to show you that in just a minute. The PCO2 is 60. That's high or acidotic. And the bicarb is 26 or 30, which is higher than 26, which is alkalotic. So now my pH is normal, but both of my parameters are not right. So what I wanted to show you here is use 7.40 as absolute normal. And so what side of absolute normal does your pH fall on? And it falls more on the acid side of normal. So it's closer to your respiratory problem than your metabolic. So this one is actually a compensated respiratory acidosis because that bicarb was able to pull the pH all the way back to the normal value. All right, the next one, pH is 7.38, and that is normal, but again, it's on the low end of normal. The PCO2 is 29, that is low, so it's alkalotic, and bicarb is 18, and that's low, so it's acidotic. In this case, if we use absolute normal as 7.40, our pH is leaning toward acidosis, so we have to go with metabolic acidosis, but it's compensated because that pH is technically in the normal range, and that was caused by that compensation of the respiratory system. So hopefully those have been some exercises that you can use to just test your knowledge of blood gases. What I'd like for you to understand is if a patient has a certain blood gas, if it's respiratory acidosis and it's caused by a certain, and you know what causes respiratory acidosis, then you can know what fixes it. So if your patient's really oversedated and they've got respiratory acidosis, then what would your intervention be? Maybe less sedation and more waking up and deep breathing. Okay, so get them to take some deep breaths and things like that. So you might see questions on the test either related to interpretation or intervention. All right, let's do a few review questions here for the pulmonary section. The nurse is providing care to a Latino patient who is hospitalized with an exacerbation of COPD. Numerous family members are present most of the time, and many of the family members are very emotional. What is the most appropriate nursing action for this patient? Restrict the number of family members visiting at one time. Inform the family that emotional outbursts are to be avoided. Make the necessary arrangements so family members can visit, or move the patient to a room at the end of the hallway. This question always gives my participants a little bit of a challenge. The correct answer is make the necessary arrangements so family members can visit. This is a cultural question. We need to understand that the Latino population confronts illness in a different way, and they show emotions in a different way than maybe we might be used to. Nowhere in the question did it say that they're interrupting anybody or aggravating anybody or causing any kind of trouble in that respect. So it's okay to have them there, but we need to make sure that we make the necessary arrangements. Now, if your question were worded differently, your answer might be different too. So my point earlier in one of the earlier modules was don't read things into the slides. Just give with the information that you're given. A patient with asthma has been prescribed an inhaled corticosteroid for control of her disease. Which patient teaching is most important for this patient? Use 2 puffs when an attack of wheezing occurs. Do not mix this medication with other inhalers. Rinse your mouth and spit immediately after use, or use of this medication should be minimized to prevent side effects. The answer in this case is rinse your mouth and spit immediately after use, because an inhaled corticosteroid, if left in the oral mucosa, can cause thrush or candidiasis. So rinse and spit is the recommendation for corticosteroids. A patient on long-term corticosteroids is receiving medication education from the nurse. In order to minimize the occurrence of one of the adverse effects of this medication, the nurse teaches the patient to know the signs of a decreased blood sugar, Maintain calcium intake of at least 1,500 milligrams per day. If nausea occurs, stop the medication for a few days, or take the medication on an empty stomach. Now, what did I say earlier about the use of corticosteroids over the long haul? They can mess up your bones and cause osteoporosis. So the correct answer is maintain calcium intake of at least 1,500 milligrams per day. Some nurses or some participants choose to say, know the signs of a decreased blood sugar? Remember that corticosteroids cause hyper, not hypoglycemia. So that's why A is not correct. When a patient is having a chest tube removed, which of these instructions would be appropriate? Take short, quick breaths with your mouth open. Take a deep breath and hold it. Breathe only through your nose, or breathe as you normally do. And the answer is take a deep breath and hold it. What we're trying to do is get the patient to create a Valsalva effect so that when we pull the tube out, they don't suck air in and exacerbate their pneumothorax. The nurse suspects that ARDS, or acute respiratory distress syndrome, is developing in a patient admitted after a near drowning. Which information supports the nurse's suspicion? The patient has intercostal retractions and is using accessory muscles. The patient's ABGs are within normal limits. The patient's lung sounds have crackles and rhonchi. Or the patient appears anxious, has dyspnea, and is tachypnic. And the answer is the patient appears anxious, has dyspnea, and is tachypnic. ARDS has all these signs, so that would be the clue that they're developing ARDS. This is one that you might see on the exam too, and I didn't talk about it in the pneumonia section, so I wanted to throw it in as a question. When positioning the patient with unilateral pneumonia, so on one side or the other, it is important to place the patient in a semi-recumbent position with the head of the bed at 30 degrees. Place the patient on the side with the bad lung down. Place the patient prone, or place the patient with the good lung down. And the answer is, and this one tends to stump people too, place the patient with the good lung down. And the reason is it's the effects of gravity on blood flow. So if you have the good lung up, blood flow is not going to be as optimal going up, so they need the good lung down. If it's a bilateral pneumonia, they should be in a semi-Fowler's position. An elderly patient who was admitted to the acute care unit with pneumonia has the following blood gas values: pH 7.32, PCO2 is 53, and bicarb is 25. What action should be taken by the nurse? So we know, oops, I'm sorry, I didn't do the answers. Obtain an order and administer diuretic. Have the patient breathe into a rebreather bag at a slow rate. Ask the patient to cough productively and take deep breaths. And obtain an order for the administration of sodium bicarb. What's their abnormality? It's respiratory acidosis. So ask the patient to cough productively and take deep breaths. He's got pneumonia. He's not breathing, he's not aerating his lungs like he should. So ask him to cough and take some deep breaths. Okay, that ends our pulmonary section or pulmonary module. So thank you once again for your attention in this section.